Thank you so much for your introduction and thanks for inviting me to come to here to give you a talk on my recent research on falls preventions for people with dementia and cognitive impairment through exercise and rehabilitation. So let me give you a very brief introduction about falls. Okay, so I don't think this is a new topic for you guys because we have been investigating the risk factors and interventions for fall preventions for a pretty long time. So in brief, I think falls can be defined as, we have several definitions for falls, but the earliest one would be the first one showing here, the events that result in the persons coming to rest unintentionally on the ground or lower level, not as a result of a major intrinsic event or an overwhelming hazard. So this is the oldest version of definition of falls. But nowadays we have a new version. Okay, we see this as an unexpected event that accounts for also some major intrinsic events such as syncope now can be regarded as a fall as well, loss of consciousness. So everything related to coming to a lower level could be regarded as falls, okay, because we can see the consequences are actually the same. So falls are pretty common in older people, but it's especially common in people with dementia. So the annual fall incidence in people with older people with dementia is around 60 to 70%. So if you know anything about falls, you can see that falls incidence in healthy older adults is only around 30 to 35%. So the risk of falls for people with dementia is actually increased by like 2 times at least. Okay, so it's 2 to 3 times more common in people with dementia, and also other complications such as fractures. The fracture rate is 3 times higher in older people with dementia. Other complications such as repeated hospitalization, nursing home admissions, premature death are also more prevalent in older people with dementia who had a fall history. So you can see that we need something to do to deal with this situation. Let's look into the false incidents in people with different diagnoses of dementia. So dementia is an umbrella term to talk about significant cognitive impairment, but there are several types of dementia as well. So in this study, they tried to investigate the false incidents of people with dementia with different types of subtypes of dementia. For the most prevalent type, Alzheimer's disease, the incidence is around 1.9, which means that if you have Alzheimer's disease, the risk of falls will be increased by 1.9 times. Okay, for those who have vascular dementia, similar, but for those with dementia with Lewy bodies and Parkinson's disease dementia, the risk of falls will be increased by 6 to 20 times. So it really depends on the types of dementias that you have, okay? But generally speaking, if you have dementia, the risk of falls will be increased by 3 times, okay, in this study, compared to healthy older adults, okay? So I think we all understand a little bit about risk factors for falls, okay? So the risk factors can be quite diverse, okay? It can be related to the physical function, cognitive function, psychological functions, fear of falling, environmental factors. All these are like risk factors for falls, and these risk factors have been widely investigated. But what about in people with dementia? Are these risk factors showing in this table are also the risk factors for falls in older people with dementia? Let's look into this. I think several studies have done previously to investigate the risk factor for falls, especially for people with cognitive impairment and dementia. So I'm showing one of these studies done in like a few years' time. So in this study, they recruited around, I think, 170 older people with cognitive impairment. So they're having mild to moderate cognitive impairment. They are living in the community. 64% of them have at least one fall, and 40% of them fell twice or more. Okay, so you can see that the prevalence is actually quite high. And they proposed that why do they have an increased risk of fall? Is because of their cognitive function. Okay, their cognitive processing speed is reduced. And when they combine with their sensory motor system and impairments, such as a reduction in their muscle strength and their gait impairments, and they may have impaired motor planning, and the responses to the loss of balance will be affected, especially in some balance challenging situations, such as when you're walking on a slippery floor, when you need to overcome some obstacles on the floor. So this may be the reasons why they fall that often compared to healthy old adults. And they evaluate a number of risk factors, and they found that these three risk factors are the most prominent ones. Postural sway when standing on foam, okay, which means that when you ask the patients to stand up straight on the floor, and you ask them to step onto a foam surface, okay, which is, well, you can see that it's not very stable for them to stand on. So we ask them to maintain as long as they can and measure the body sway. So if you have an increased body sway when you're standing on foam, you have around 2 times increase the risk of fall. The second one is coordinated stability, which means that when you ask the patients to stand on the ground, and then you ask them to move the upper body without moving their feet. Okay, so if the patients can move further away from the center of gravity, they have a better balance. They will have a better stability. But if they lose the balance when they move the upper trunk, they may have a poor coordinated stability. If you have problem in this aspect, you have an increase of the risk by 1.7%, 1.7 times. Okay, and also if you have the depression symptoms, you are also very likely to fall as well. Okay, in this study. What about other domains such as cognitive function? So cognitive function is also related to falls in older people, right? Um, This is another study done by the same group of researchers in Australia. So they tried to investigate the associations of different cognitive domains and falls in people with mild to moderate cognitive impairment. And they found that processing speed, executive function, visual spatial ability, and affects are the potential risk factors for falls in people with cognitive impairment. And you can see that the executive function is the most prominent, the strongest predictor for falls among all the other neuropsychological domains. And they propose that if you have a poor executive function, your processing speed will be reduced, especially when you need to process some environmental challenges, such as external perturbations when you get pushed by other people when you walk out on the street. And you may have a reduced attention span when we need to maintain balance. So that's why these people who have poor executive functions may be more likely to fall. Okay. And they also found that older people with poorer executive functions have worse spatial spatial function, hand reaction time, knee extension strain, posture strain, and coordinated stability as well. And they also found that reaction time and posture rate on foam surface significantly mediates the relationship between executive function and multiple falls, which means that if you have a poor executive function, but if you have some other ways to improve your reaction time or posture rate, your risk of fall will be reduced by around 30%. So these are the potential mediators, which also means that if you have any interventions to improve reaction time and posture rate in people with reduced executive function, which is very common among people with dementia, we may be able to reduce the risk of fall. So let's look at another common risk factor for falls, which is gait, okay, the walking ability and performances. So this is a very big study done in 2017, and they found that older people with non-AD dementia are more likely to fall than those with AD. Okay, with non-AD dementias include vascular dementia, some other subtypes such as Lewy bodies and Parkinson's disease dementia. As I mentioned before, people with Lewy bodies and like Parkinson's disease dementias are very likely to fall because they have some motor symptoms as well. Okay, so that's one of the reasons why older people with non-AD dementias are more likely to fall. And they also found that reduced gait speed is consistently associated with falls across different spectrum of cognitive impairment, ranging from mild cognitive impairment, mild dementia, non-AD, AD, and moderate dementia. So, so you can see that gait speed itself it's a very easy way to measure how well a person perform in GATE performance. You can make use of this measure to estimate the fall risk in people with dementia. So in brief summary, physical function, including balance and gait, is associated with falls in older people with cognitive impairment and dementia. Certain physical domains mediate the association between cognitive impairment and falls in this population. So that's why we need to think about whether we have some effective ways to assess physical function and interventions that can improve both cognitive and physical function in these populations to reduce the fall risk. So do we have any effective ways to assess the physical function and improve physical function in this population group? That's the question. So let's look into the assessment first. Okay, so I would like to give you a term called physical performance, which is quite similar to physical function, but it refers to some physical domains directly related to the lower limb performances, including general mobility, gait, balance, and lower limb muscle strength. Previous studies have done a lot to evaluate the associations of physical performance and falls in healthy older adults and also people with dementia and cognitive impairment. But these studies are usually quite discrete. They recruited small group of people with dementia. They only focus on several certain physical domains such as gait and balance, and to evaluate the relationship between falls and physical performances. So that's why we conducted a systematic review and meta-analysis to evaluate the association between physical performance and falls in this population group. And we would like to see whether we can make use of any physical performance measures to predict falls in this population. So this is a meta-analysis that we've done previously, and it has been accepted by JAMDA, and I think you can see the full version very soon in July or August. So we try to dig out the studies that used measures to assess at least one of the four physical performance domains in older adults with dementia to examine the association between these domains with falls or to discriminate between fallers and non-fallers in this population. So here are the results. For muscle strength measures, we found that 5 times chair stand tests and also hand grip strength tests are very effective in identifying fallers in people with dementia. So for example, for hand grip strength, if you have poorer hand grip strength, you are more likely to fall in this population group, and the fallers are perform significantly poorer in hand grip strength. For balance measures, we found that balance scale, okay, which is a composite measures of static and dynamic balance in older people. Posture straight when standing on floor with eyes open, and standing on foam surface with eyes open are all very effective in identifying fallers in this population group. So if you have an increased body rate, you're more likely to fall. So as you can see in these figures. For mobility measures, time up and go test, which is a very common popular test to test mobility in older people. And also another tool called short physical performance battery, okay, which are also very effective in identifying fallers. So short physical performance battery is a composite measures that measures balance, gait speed, and also lower limb strength. Okay, so when they complete all the tests, they calculate the score of the performance, and they so this tool is very popular, especially in research area. And for gait measures, we actually didn't find any positive test results. But when we do a subgroup analysis, we found that gait speed cannot actually identify fallers in those who are living in the community. However, when you apply gait speed test among those who are living in nursing homes or staying in hospitals, this tool becomes very effective in identifying fallers. So when if they have a history of fall or if they have a prospective fall in the following year, they're more likely to have a reduced gait speed. So that's why gait speed could be a very sensitive tool to detect fallers, but this can be only applied to those who are institutionalized. So I hope that you can apply all these tests to evaluate the fall risk of people with dementia. But of course, you can always combine these physical measures with other measures such as cognitive and psychological measures to predict falls. So what about execution? So I'm sure that the audience, I believe that some of you guys are very like experienced clinicians. You may have experience in dealing with people with dementia. If you have ever conducted any physical performance test among people with dementia, you may come up with a lot of like bad experiences because it's very challenging for us to execute physical performance tests in people with dementias because they may not be able to listen to our instructions. They may forget our procedures. They may get lost in the middle of the test and they will just stand there or they just run away. Okay, so it's very challenging for us to ask the patients with dementias to complete the physical test. It may be because of their reduced attention. They have problems with their short-term memory, so that's why they are unable to remember all the instructions and testing procedures. For those who have moderate or to severe dementias, they may also have some behavioral and psychological symptoms. So they may get distracted. They may have other like behavioral problems that may affect their adherence to physical tests. So that's why we need to think about whether we have any things to make sure that they can complete the test first so that we can gather the results. And also we have to think about whether we have any ways to improve the accuracy and consistency of the test. So here are some recommended approaches made by some previous researchers. So first of all, we need to make sure that we have an appropriate venue for our physical test. So I think most of the people with dementias prefer to stay at a quiet, spacious area that are familiar with them to do some physical assessments. The next thing is that we need to use a sequential approach to make sure that our instructions and procedures are simple enough for them to execute. We also need to consider whether we can incorporate some external cues during the test, such as verbal, physical, and visual cues. We also need to develop tools that are specific to their needs and problems when we evaluate their physical performance. So remember, all our physical tests are originally designed and developed for healthy old adults, not people with dementia. So that's why these tests may not be applicable to people with dementia. So that's why we try to find out which test is the best for people with dementia, and then we found this one, backward walking test. So backward walking in nature is a daily task that everyone needs to do every day. Okay, it demands higher balance and gait control and more cognitive resources compared to forward walking due to the reduced visual input. But it's still very functional, and I believe that most of the people with dementia can do it successfully. So this test has been developed for people with healthy old adults, but it has not been thoroughly investigated among people with dementia. So that's why we conduct a study to investigate the feasibility and also the psychometric properties of this test in people with dementia. So the test itself is very simple. We ask the patients to stand at the starting points here, and then we have a 6-meter corridor for them to walk backward. And then we put some markers on the floor to make sure that we know when to start timer and end the timer to measure the walking speed. The first 1.5 meter and the last 1.5 meter will be the acceleration and deceleration phase of the walking. And when the persons walk in the middle of the 3 meters of the corridor, we mention the time that they spend on the corridor, and then we calculate the walking speed. So we also incorporate a queuing system when we conduct the test. So the first one, I think we can incorporate some verbal and physical cues in the middle of the test to make sure that they can complete the test successfully. Okay. So it's a small study. Okay, we recruited 30 people, and the mean age is around 83, and the MMSE score is 15, which means that they have more mild to moderate dementia. The test reliability is very good. And majority of the participants require no cue and verbal cue only, which means that the cognitive demand of this test is very little. among this population group. And we also found that this test can differentiate people who use and who do not use walking aids. We also try to use this test to differentiate whether we can use this test to identify fallers, okay, in this population group, certain group. However, because the sample size is rather small, we could not see any significant difference between fallers and non-fallers in this test. But we assume that because you can see the magnitude of the performance of the non-fallers and fallers is actually quite big. So we expect that when you're able to recruit a bigger sample, we will see the significant difference in the test between fallers and non-fallers. And we are actually doing that right now. We're trying to recruit more subjects to see whether they have a different performances in this test. So let's talk about intervention. Stepping is one of the ways that we can improve balance and physical function and reduce fall risk in older population group. Stepping has been regarded as the most common strategy for older people to prevent falls. Okay, so imagine that you're going to lose balance. You need to take a big step, okay, to make sure they can stand upright, right? And stepping performances can be further divided into reactive stepping and volitional stepping. And especially for volitional stepping, it is determined by both physical function and cognitive function. So physical function is understood, okay? They need to have a good muscle strength, balance, and reaction time to execute the stepping, right? But what about cognitive function? So let's imagine that you are walking on a parallel bar, okay? You need to see what is happening in the environment, use the brain to process the information, and then execute the step. You need to decide where you put the foot, how big the step is, etc. So that's why stepping involves, especially volitional stepping, involves a lot of cognitive function. So we have another term called choice stepping, which is a concurrent primary stepping task and a secondary visual spatial task that demand balance and weight shifting and executive function. And we expect that people with cognitive impairment have poorer performance in choice stepping compared to those with normal older adults. So that's why we can make use of this idea to design an intervention for this population group to reduce the fall risk. So step training is not a kind of new intervention anymore because I think some people have done a systematic review and they found that step training can reduce fall risk by 50%, which is very impressive because most of the exercise interventions can only reduce fall risk by only 20%. But we are not quite sure whether this concept can apply to people with dementia. So that's why we conducted a pilot study to evaluate the effects of step training in people with dementia. So, we recruited 56 individuals who have dementia and who are able to walk independently indoor. So we designed a step training program, which is a 12-week long with two 30-minute sections per week. And all the participants are instructed by exercise instructor to use their feet to step on some specific target located on the plastic mat on the floor. Okay, so we progressed the training intensity by increasing the distance between the person and the stepping panel, the directions of planning, stepping, and also we all incorporate some cognitive tasks as well in the training. So in this study, we recruited 56 people and 22 people joined the intervention group and 26 people joined the intervention group and most of the people have completed all the 12-week assessments. The mean age is around 80. The mean Mocha score is around 10 to 11. So you can see that they have mild to moderate dementia. Here are the outcomes of the study. We can see that they have a significant improvement in their choice stepping reaction time. Step length, okay, we asked them to step as far as possible, and we found that they have an increase in the step length. Another step test called alternate step test, which is highly correlated with balance in older people. So we can see that they have a significant improvement in multiple aspects of their stepping performance. What about physical and cognitive outcomes? We didn't see any significant improvements in these outcomes, such as walker, walking speed, general mobility, etc. But because it is a pilot study, this study is not powered to see any significant changes in these physical and cognitive outcomes. So we didn't expect that these outcomes will have a significant improvement. But we hope that when we have a chance to recruit a bigger sample size, we will be able to see some changes here. So we can see that step training program is feasible, safe, and effective in improving stepping performance in older people with mild to moderate dementia. And we hope that we will have a chance to carry out a bigger study, to big RCT to evaluate the effects. So these are take-home messages. Okay, falls are very common in older people with dementia. Risk factor for falls in older people with dementia may not be exactly the same as those in healthy older adults. So we need to use different ways to evaluate the risk factors. Physical performance measures that I mentioned before can be used to predict falls in this population group. Fall prevention program for older people with dementias need to be tailored to the needs and problems found in this population group. And step training could be one of the solutions to reduce the fall rates. So I would like to thank PolyU and UGC for their funding to support our research, and also the support from NGOs and all the participants that have been participating in our studies. So that's all I have to say. Thank you so much. Sorry about the time. I think I overran a little bit, but thank you so much for listening. And if you have any questions, please come to me anytime.